right, well, I guess we'll go ahead and get started. Talk a little bit about what's new in nuclear cardiology. So we're going to concentrate on several issues. We're going to talk about pharmacologic agents, new stressors. We're going to talk about reducing radiation exposure techniques. A lot has to do with that, with new hardware and software issues, as well as changing what we do, which includes stress-only imaging, which we'll talk about. Advances in gamma camera technology, which allows us now to actually potentially define absolute blood flow even with SPECT systems, and also some new novel radio tracers and applications. So first of all, let's start off with the with stressor agents. As you know, we have a lot of difficulty in patients who can't exercise, and in this regard, then we've used pharmacologic agents, which apply to about 50% of our population now. And as you know, adenosine was one of the first agents to come around, but it's a non-selective adenosine agonist. And there are actually many different adenosine receptors, one being the A2A, which is the receptor that causes coronary vasodilation. Whoops. But there's also the A1, which causes a decrease in AV conduction, the A2Bs, which can cause peripheral vasodilation, and activation of the A3s, which can lead to bronchospasm. So if you could specifically find a selective A2A agonist, it would be a marked improvement. In fact, different A2A agonists have been developed. One of them is Regadenoson, which we use on our own laboratory quite frequently now, in fact, almost exclusively. And it was actually approved by FDA based on the data from the ADVANCE 1 and 2 studies, which were studies looking at the ability of adenosine, initial adenosine studies versus Regadenoson to show comparable degrees of ischemia detection as compared to serial adenosine images. And in this particular study, you can see that in the first trial, serial adenosine imaging in terms of detection of ischemia was 61% based on analysis by 3 expert interpreters, and 62% with adenosine versus Regadenoson. And same thing in the ADVANCE 2 study, the second study, very comparable in terms of detection of ischemia. And based on those data, FDA approved Regadenoson as a pharmacologic stressor agent. We've also published our own data from the ADVANCE study looking at quantitative analysis. That's in almost 2,000 patients, showing a very nice correlation between perfusion defect size determined by adenosine as compared to perfusion defect size determined by Regadenoson. And that has to do with both total defect size, as shown in the top graph, as well as ischemic defect size, as shown in the bottom graph. Now, if you look at Bland-Altman analysis, you can also see a very tight correlation between what you see with adenosine and what you see with Regadenoson. And in fact, based on these data, it would appear that Regadenoson and adenosine actually induce almost identical perfusion defects. And you can see this is just an example of one patient who had an adenosine study who had a 40% defect, and a Regadenoson study with a 40% defect. Notice that the location of the defect is almost identical. The ischemic area is the green, so the ischemic area is almost identical. And in this regard, it would appear that Regadenoson, clearly from a diagnostic point of view, is comparable to adenosine, and probably from a prognostic view as well, although there really aren't those kind of prognostic studies published yet. But based on the size of the defect and the fact that you can induce defects the same size, probably from a prognostic point of view, Regadenoson should perform as well as adenosine. The other important thing about Regadenoson was the issue that in many trials, it was shown safe in patients with moderate to severe COPD and mild to moderate asthma, which, as you know, with adenosine is a relative contraindication in that population due to the induction of reactive airway disease. And remember that Regadenoson should perform better because it doesn't activate the A3 receptor to any great degree as compared to what you see with adenosine. And in fact, in this particular trial, which was the largest study in 999 patients, where FEV1s by serial pulmonary function test was assessed, there was no difference in terms of a drop in FEV1 with Regadenoson versus placebo, which was saline infusion, okay? So a very strong statement showing safety in a group of patients who otherwise would usually go for dobutamine imaging. And now we don't use dobutamine at all. I don't think we've ever pulled it out of the cupboard, so to speak. It just isn't used because, and I don't particularly like dobutamine anyway. It has a lot of side effects, and I used to cause my heart rate to go up higher than the patient's when I used dobutamine. But we don't use it anymore because of the safety that we have with Regadenoson. The other issue is in terms of subpopulations. With Regadenoson, there's been shown safety in patients who are post-transplant. And if you look at the data with adenosine, it's clear that many of those patients would end up having problems with AV conduction. But if you look at the data with Regadenoson, basically nobody developed second-degree or third-degree AV block. And in terms of even sinus pauses, that was much less significant with Regadenoson as compared to adenosine. And so this can actually be used to assess patients post-transplant safely. Now, whether using these kind of agents actually is diagnostically and prognostically validated remains to be seen. But from a safety point of view, Regadenoson is clearly safer in this population. The other issue becomes when you can use these different agents with exercise. And that becomes important because there are many patients who you think might be able to do a treadmill test, and you'd like them to do a treadmill test, but so you start off with treadmill first, and then you realize they're going to do a submaximal effort, and they're not going to be able to achieve 85% of their predicted heart rate, and you need to change to a pharmacologic stress test. Well, there actually have been several studies with adenosine, which have shown that you can use adenosine with low-level exercise and can do that safely without any difference in diagnostic accuracy, and in fact with some improvement in overall image quality due to the addition of using exercise and cutting off splanchnic blood flows, relatively speaking, so you don't get as much liver uptake with technetium-type products. There are also multiple studies and very, very small studies using Regadenoson in which patients have used low-level exercise initially, or where patients have actually been put on the treadmill, got up to peak exercise, and actually been injected at peak exercise with Regadenoson, and some still where patients have been brought down to lower levels of exercise and then had Regadenoson injection. And in fact, the largest study to date so far, and the only randomized trial looking at this, is the EXERRT trial, which was just published in the Journal of Nuclear Cardiology in some 1,400 patients, in which patients who could not achieve greater than 85% of their predicted heart rate were actually then randomized to waiting an hour and then undergoing Regadenoson imaging, or having Regadenoson imaging 3 minutes into the recovery phase of a submaximal exercise test. And so here you can see that the study design. Everyone had a rest first study, followed by a stress study. That was in 96% of the patients had rest stress imaging on the same day. And if they could not achieve greater than 85% of their heart rate, or at least 5 METs, they were randomized. You can see here, within 3 minutes, they received the Regadenoson and then were imaged. In this group, they waited an hour and then were given Regadenoson and were imaged. And then everybody had a second stress first set of images 1 to 2 weeks later to compare the stress Regadenoson early after terminating exercise to the second stress, and vice versa, the Regadenoson 1 hour after terminating exercise to the second stress, okay? If you look at the hemodynamic changes, there were really no significant differences between the populations. Yes?
What's the rationale for waiting an hour?
Safety. Okay, so the issue is safety. Whether you could, by waiting an hour, you've basically gotten rid of any of the pharmacologic effects of the drug. So that would be like almost starting out fresh without having had, I'm sorry, without, by waiting an hour, you've really, the patient has been in full rest mode, okay? So the idea was to, and what's typically done now is patients are stopped for about, half an hour, 45 minutes to an hour to bring their heart rates down, to make sure they're clinically stable before giving the drug. okay? The idea here is whether you could promote a protocol where you could just right after exercise, then initiate right away, right while they're on the treadmill, give Regadenoson, and then perform the stress test early on and get it done. So that was the rationale. If you look at the hemodynamic changes, there were really no significance between Regadenoson at rest or with stress in terms of changes in blood pressure or heart rate. And if you look at improvement, secondary endpoints such as image quality, there was actually improvement in the heart-to-target ratios because of less uptake in the gut in the patients who could exercise. But this, even though there was improvement there, most of the studies were of high quality, so it really didn't impact the outcome. Now, what's interesting here is there actually were some patients who had problems with getting Regadenoson after exercise. And as you can see here, in terms of the cardiac events, there were actually 2 patients in the exercise Regadenoson group, one who had an acute coronary syndrome and had to be taken to the cath lab, and another patient who developed a myocardial infarction. So that was 0.3% of the population. What's interesting about both of these patients is that they had ST segment depression even before they received Regadenoson. And in hindsight, should never have received Regadenoson. I mean, once you already have evidence of ST segment depression and ischemia, it doesn't make sense to then give another pharmacologic agent, right, after you've given stress. So again, the moral to this story is there's no value and potential harm to administering Regadenoson to patients who already demonstrate ischemia. And we know from other data many years ago that sometimes about 20% of patients, 10 to 20% of patients will actually develop ST segment depression only into recovery, okay? So that 3-minute wait is actually very important because when someone stops on the treadmill and is in that 3-minute resting period, they may develop ST segment depression, and we know those patients do as badly as those who develop ST segment depression during exercise. So in this regard, I think in terms of the investigators, they were very wise to use that kind of 3-minute window to let people cool down, and you can actually see then if someone were to develop ST segment depression, and those patients, clearly, they would not be patients you would give Regadenoson to. All right? So again, all of this highlights the importance of the 3-minute recovery phase, not to administer right on the fly when they're at maximal exercise, but to cool them down, cool the patient down, and wait 3 minutes before administering Regadenoson. The other thing that's interesting about this trial is when you look at the exercise Regadenoson versus the Regadenoson groups, it turns out that the comparability in terms of detecting ischemia were very comparable. I mean, 73 and 75%. And you think, well, that's great. You know, that's non-inferiority, okay? But what's also very interesting is that when you look at the exercise Regadenoson study versus the second study, there was much more new detection of ischemia on the second stress test than on the initial rest stress protocol, okay? Now, why is that important? Because still, to this day, people tend to do rest stress imaging protocols. Now, we don't do that here. Because, of course, stress-only imaging is what we tend to do here with the stress-rest protocol. But there is some concern that if you inject somebody after having a resting injection and then stress them and give them another injection of technetium, you may get shine-through from the lower resting dose. And that may actually hide any potential ischemia that you might have induced with the stressor. Okay? And in fact, in this study, this is really the first randomized look at this. I mean, it's been suggested for years that that's a possibility, but this study actually shows that, about 8.5% of patients developed new ischemia on the second stress because they weren't contaminated by the first rest injection on the first set of imaging, the rest stress imaging. So something to keep in mind, and again, that's one of the reasons why we like stress-rest imaging and why we use a lot of stress-only imaging. And of course, you're all familiar with these data. These are from our lab as well as Duval's lab, showing that half of our patients can actually undergo stress-only imaging, and with comparable outcomes in terms of no bad events. and in fact, with much less radiation exposure. And in fact, in our studies, less than 5 millisieverts of radiation exposure in 60% of the patients who had stress-only imaging. So this is a marked improvement and can be achieved just by changing what you do. Instead of doing rest-stress, simply doing stress first, and then allowing you to do stress only, and maybe even in the showing from the previous study, from the EXERRT trial, maybe even detecting more ischemia by doing stress first than doing a rest-stress protocol. There's also data from Henslova showing the value of reducing not only radiation exposure to the patient, but also to the staff. And this is looking at a series of readings, of dosimetry readings, 1 year prior to initiation of CZT and stress only compared to 1 year after using CZT and stress only. And you can see that there was a marked reduction in personnel radiation dosimetry readings. This was when you look at deep dose, shallow dose, or lens dose equivalents. And in fact, what's interesting also is that even though using CZT technology and reducing the dose did help in terms of reducing radiation exposure to personnel, most of that benefit was from stress-only imaging, from doing stress first and allowing people to only have a stress dose. We have published last year, Dr. Nabi looked at the issue of comparing CT angiography to nuclear imaging using a stress-only algorithm, where if someone went for a stress study and it was normal, they wouldn't get a rest dose. And so we actually randomized people to myocardial perfusion imaging or to CT angiography. We followed those patients for about 6 months. They had similar baseline characteristics. As you can see here, BMI 32, not exactly small patients. 15% had diabetes, half had hypertension. And their TIMI risk score, as you can see here, most of them had low TIMI risk scores. Most of them had a TIMI risk score of 1. Again, in this study, stress-only imaging was achieved in about a quarter of the patients. And from a CT perspective, we did prospective imaging in 20% and dose modulation in 35%. So we got pretty good CT dose reductions as well. Most of these patients, as you might suspect because they're low intermediate risk patients, had normal studies. If you look at this particular slide, the blue is the time from hospital admission to actually arriving in the lab for injection of the radiotracer. The green is the time from randomization to study completion. The yellow is the time from study completion to interpretation. And the red is from interpretation to hospital discharge. And what you'll notice when you look at all SPECT studies or all CTAs, it's true that CTA does reduce the time of performing the study, maybe, but really no difference in terms of interpreting. But if you look at the group with normal CTAs and normal stress only, you can see that it's very comparable in terms of not only procedural times, but also in terms of interpretation times. And that's in comparison to stress rest imaging, where the procedures, generally speaking, took several hours later, like 3.5 hours later, okay? So stress-only imaging allows you to do things much more effectively. And in fact, in this particular study, as a final conclusion, the time to diagnosis was very similar with MPI versus CT. The time to hospital discharge was also similar. Radiation exposure was less with myocardial perfusion imaging using stress only than it was with CTA, and hospital costs were comparable. And since most patients are going to have a normal stress study in these low to intermediate risk patients who come through the ED, it makes sense then to use a stress rest imaging protocol with the likelihood then of doing stress-only imaging. Now, it's kind of interesting because if you look at the ASNC guidelines, they really buy into this. They buy into the fact.
What was the percent of patients requiring both stress and rest?
In this particular study, 50% of the patients had stress rest, 26% had stress only, and half of them had rest stress. This was before we converted over to basically all stress first. We had at one point done rest stress because of the need to try to get patients out of the hospital within 24 hours. We learned from these data that most of those patients, if you do them stress first, they're going to be normal anyway, and they're not going to require, and even the ones who get high initial doses and might be 2-day protocols, we can do other kind of techniques such as prone imaging and also attenuation correction to help reduce the number of patients who have to have a 2-day study. And in fact, that turns out to be a very, very small percent of our patient population now.
So, but going back to the question,
Yes.
in that patient population that comes to the ED,
Yeah.
what's the normalcy rate? Because that you'll stop at stress first.
Well, I mean, if you look at the overall population, 95% had normal studies. 95%. The vast majority. Yeah.
So why Dr. Mahmarian was most of the scans during the spectrum was
Well, because if you look at the BMIs, they were like 32. Okay, so it's not as though we have small patients, right? And a lot of them had higher heart rates because when they come to the ED, they're not exactly. This was before we had our new Siemens system, right? This was using the old 64 slice. Okay, but you have to remember that in this day and age, still most people image on 64 slice scanners, right? We're just lucky that we actually have a scanner that is dual source and can work well with high heart rates. Okay. So anyway, in terms of stress only, it's been approved. It's been sanctioned by ASNC. There have also been many different editorials on this in terms of the use of stress-only imaging by several different investigators over the years. And yet, despite all of that, we find that stress-only imaging is still not embraced by most people. And in fact, this is a study we published last year, the INCAP study, which was the International Atomic Energy Agency. I was involved with them over the last several years when I was ASNC president and into that time frame. And we devised this study to look at what typical laboratories do in terms of imaging protocols. And so data were collected actually on almost 8,000 patients in 308 laboratories in 65 countries across the world, looking at how many groups use radiation reduction techniques. And you can see these different laboratories here in terms of European, Latin America, North America, et cetera, et cetera. What's interesting about these data is that when you look at the stress first utilization, it's actually extremely low, and most impressive is how low it is in North America. So again, most people are using rest stress rather than stress first. And of course, when you do stress first, that limits your ability to do stress only. So in North America, where we pride ourselves on having the best imaging and doing the best techniques, we're actually worse than Africa and Asia, okay, in terms of being able to really do proper imaging. And in fact, only 3% of patients in North America in this study underwent stress only. And if you look at, obviously, the radiation dose, it could have been decreased significantly if they had used stress only, but unfortunately, in most laboratories, it was not. So when you look at the overall radiation dose across all sites, and then you look at North America, you can see that only 30% of patients in North America actually achieved ASNC's goal, which is less than 9 millisieverts. And of course, we even think that's way too high. Like I said, with our own stress-only protocols, we get down to less than 5 millisieverts in the majority of patients. So it just shows you we have a lot of work still to do. We need to get the message out. And obviously, there's a lot of PR on all sides to try to do this. Let's talk about some other things. What about technical issues? You know, nuclear cardiology is limited by its energy resolution due to sodium iodide crystals, the need for PM tubes, limited spatial resolution, et cetera, because of PM tubes, low camera sensitivity. This is one of the most important things that we don't appreciate. Over 99% of all photons that come off the patient never hit the gamma camera, never hit the crystal, all right? Because especially if you don't have the camera very close to the patient, okay, you're going to lose a lot of counts. And then Remember, these photons are going in all different directions. Only those that are parallel are going to get in and hit the gamma camera crystal. So most photons are lost, which is unfortunate because we really need to have a high photon flux to get good results. Right now, there are several CZT type cameras out there, and CZT is much nicer because it has increased sensitivity just by the basis of the crystal. Plus, we don't have PM tubes when we use CZT cameras. It's all electronics. And the lack of PM tubes and the direct production of electrical current without the use of PM tubes is a great advantage with the use of CZT. If you look at the different systems that have been studied over the years, they all are pretty comparable in terms of being able to lower radiation exposure and getting comparable results. And this can be done several ways. It can be done using half-time or full-time imaging. This is a study using a CZT camera technology by Duval. This is using technetium 5 millicuries at rest and 15 millicuries at stress. So this is a 5-minute rest and an 8-minute rest study, and you can see no difference in terms of image quality. This is using a 3-minute stress acquisition versus a 5-minute stress acquisition, no difference in terms of image quality. And that's compared to a 15-minute stress at the bottom using conventional technology. So with CZT technology, you can really you can do one of two things. You can either have very short acquisitions at full dose, or you can double the acquisition time and give half the dose of radiopharmaceutical. And obviously this is important because we know that if we want to reduce radiation exposure, if we just use, for instance, 5 millicuries at stress, we can get down to 1 to 2 millisieverts of radiation exposure, as compared to all of these other ways in which we do things which lead to much higher radiation. And of course, we have to remember, especially with what the kind of systems we have here, that radiation exposure reducing techniques are very much in vogue with CT systems as well. So to be competitive, we really need to be able to do this and use new technology. The other thing we can do is we can use iterative reconstruction. Every single technique, if you look at CT uses iterative reconstruction rather than filtered back projection. Nuclear uses iterative reconstruction. It's a way of cutting your dose by about 1/3. And if you cut your dose by about 1/3, you can see the radiation exposure reductions would be significant. And when you look at conventional imaging versus using half dose and full acquisition times with these kind of systems, you get basically comparable imaging. And in fact, if you look at this is a study from Adahi. This was a study I participated in, where if you look at the full-time half dose versus the half-time full dose images, they're identical. And so these are ways to have flexibility in the way you image, and yet at the same time to reduce the amount of radiation exposure in higher risk individuals who, let's say, are more compliant, are able to lie for longer periods of time under the camera without moving, etc. So if you have, if you have a 45-year-old woman who can spend, 10-minute acquisition instead of having to have a 5-minute acquisition, you can use half dose and get a marked reduction in radiation exposure. Okay. The other thing that we do now, or we're trying to do, is mimic PET. And one of the areas is in terms of looking at absolute blood flow. And as you know, there have been many studies, and this happens to be a study using rubidium, but there have been studies using O15 water. There have been studies, which is the gold standard, incidentally. There have been studies using N13 ammonia. And there are also studies like this one using rubidium to look at absolute coronary blood flow. And in fact, if you look at this particular study with PET, looking at total defect size in people who had triple vessel or single vessel disease using standard methodology, which would be normalization to the highest count in the myocardium, versus an absolute blood flow method, either subtracting stress from rest and looking at the reserve, or to do a ratio of stress or rest, you can see that the defect sizes were considerably higher in those with triple vessel disease using both of the absolute blood flow techniques as compared to relative blood flow techniques using in people with triple vessel disease. Not single vessel disease, but in those with advanced triple vessel disease. And this has been an argument and has been an advantage for the use of PET imaging over the years in terms of someone having what appears to be a relatively normal myocardial perfusion scan and then being able to identify those small subset of patients who have underlying severe balanced ischemia, which you can do with absolute blood flow. Well, now there are maybe some ways to do that also with SPECT imaging. And this is actually a study looking at patients with, it's a small series, looking at patients with known coronary artery disease using dynamic SPECT on a Siemens system and looking at actual first pass acquisition of data. Now, it's kind of interesting. 30 years ago, in nuclear cardiology, we had a system called the Baird system, which was a multi-crystal camera. And we used to do first pass studies all the time. It was a big bulky camera, but you'd put the patient up there, and it was mainly to look at right ventricular ejection fraction and left ventricular ejection fraction at the same time. You could do, as the bolus passed through the right ventricle into the pulmonary circuit and then back to the left ventricle. That obviously is not the purpose here. The purpose here is actually to look at dynamic flow within the myocardium using an agent that is taken up by the myocardium. So in the old days, we did technetium studies with the Baird camera looking at first pass ejection fractions. By using sestamib or tetraphosphamine, technetium tagged myocardial perfusion agents, we can now look at uptake within the myocardium. And you can see here, both on the top images, you can see rest and stress images, and you can see the blood pool clearing and gradually the myocardium lighting up as the technetium is taken up by the myocardium. If you look at this particular study and look at patients with normal coronaries versus abnormal coronaries, globally or by vessel territory, you can see that that maximal blood flow during stress was different in terms of absolute increase in blood flow. And so a nice differentiation between normal and abnormal, much like what you would see with PET imaging with absolute blood flow measurements. That's looking at stress myocardial blood flow, but then let's look at myocardial flow reserve, which is obviously the ratio of stress and rest. So here you'll see that in patients with either global coronary disease or with isolated single vessel disease in the LED circle right, that the myocardial flow reserve is about half of what you see in the normal regions, okay? So this is what we actually see when we do PET imaging. We look at regional myocardial flow reserve and regional maximal coronary blood flow. And it would appear, at least based on these data, that we can also might be able to do this successfully with SPECT. And in fact, you can see the advantage here, both from a patient-based analysis as well as from a vessel-based analysis in terms of the ROC curves, using a quantitative approach as compared to simply a standard approach, which would be looking at the patient, looking at the normalized data. And so here's a patient on the right-hand side that has normal myocardial perfusion, and yet you can see that in all areas of the myocardium, when you look at maximal blood flow or myocardial flow reserve, it's all depressed, and this patient ended up having triple vessel disease, okay? So in a subset of patients, we think this may be very helpful. In those with suspected triple vessel disease, this may be very helpful in terms of being able to look at myocardial blood flow categorically. This has also, incidentally, the same kind of technique has been not only compared to angiography, but has been compared to N13 ammonia PET. This is using a CZT comparison, a CZT SPECT camera versus N13 ammonia. And again, the same rationale of using a first pass technique and acquiring the data very rapidly, which can be done with CZT technology and the increased sensitivity of the camera. And here you can see CZT images and ammonia images, and they're virtually identical with even the same abnormalities in terms of perfusion defects shown on the polar maps. And in this study, in fact, there was actually good correlation between CZT and PET. What was interesting, though, is that when you look at PET and you look at CZT, notice that the myocardial blood flow was higher with N13 as compared to CZT. And this isn't across all groups, okay? And why is that interesting? And why is that not unexpected? Because we know that there's a tremendous amount of rollover in flows using technetium at high flows, right? We know that N13 ammonia is more linear across all blood flows as compared to technetium. So it's not surprising that there was some difference in terms of maximal flow as well as relative flow reserve using technetium, but still a nice correlation between the two, and that could actually be corrected by a mathematical aneurysm. I also want to impress upon you that even though technetium has a low fractional flow reserve at high flows, it's really no different than what you see with rubidium. And so even though rubidium is now used as the #1 PET agent, it still has limitations in terms of its ability to detect maximal flow because you get rollover with rubidium at very high flows, just like you do with technetium. There is some potential in the future with this agent, flurpiridaz. This is an F18 agent. It's nice because you can get away with, again, very low radiation exposure, very comparable to what you would see with rubidium or N13 ammonia. In fact, even better than what you see with rubidium, which still has about 5 to 10 millisieverts of radiation associated with it, depending on the patient population you look at it, how much dose you need to give. If you look at the differences between rubidium and flurpiridaz, one of the things that strikes you is the very short half-life of rubidium as compared to F18, which is almost 2 hours. What does that mean? That means with rubidium, you cannot do exercise. You can only do pharmacologic stress. And we know that exercise has a lot of advantages, and that's why we do exercise with perfusion imaging. With rubidium, you can't do that. But with flurpiridaz, being an F18 agent, you would be able to do that in terms of applying exercise rather than simply doing pharmacologic stress testing. The other thing I want to emphasize is the issue of energy. If you look at the positron range of rubidium, it's 8.6 millimeters. It's 8.6 millimeters compared to 1 millimeter with F18. Now, you all know that when these things annihilate, they annihilate at a certain kV, at the same kV, right? But every single one of these PET agents has their own intrinsic energy. So if they're very high energy, they will annihilate further from where they were emitted than if they have a low energy. Okay, that's very important. And you can see that here in this diagram. If you had a pinpoint source, look at the spatial resolution of rubidium as compared to what would be using the same point source using flurpiridaz. Again, because of the very short positron range of F18, which is a tremendous advantage in terms of, or would be a tremendous advantage in terms of PET imaging. The other thing is that if you look at the myocardial extraction fraction, as I said, with rubidium, it's no better than what you get with technetium. But look at flurpiridaz, it's almost linear to blood flow, okay? And that's very important. So if you look at O15 water, which is the gold standard, it's completely linear across all blood flows. If you look at flurpiridaz, it's extremely similar, okay, to F18 water. And in fact, if you were to compare an O15 water study to a flurpiridaz study, you would only lose about 5% in terms of defect size detection based on changes in counts from stress to rest with flurpiridaz as compared to O15 water. Look at what you would look at with rubidium or technetium agents. Okay, so now you get a much, because of the rollover, you get a much smaller defect and much less ability to detect perfusion abnormalities. So we think that, this, again, because of the extraction fraction of flurpiridaz, this may be a very good agent. And in fact, in initial studies, this is the first phase 3 study that was published. Flurpiridaz showed better sensitivity, almost 90% compared to technetium studies of 74. And in terms of overall image quality, it was also better. Interestingly enough, in terms of specificity, it wasn't much different than technetium. But in terms of sensitivity, it was. And that makes sense, again, because of the enhanced extraction at high flows. Okay? Just an example. Okay. Let's again change gears here a little bit and talk about imaging heart failure. Okay? So in the next couple of minutes, we're going to talk about this.
John,
Yes?
can you give us an update on flurpiridaz?
Flurpiridaz is now starting its second phase 3 study. There's been a lot of issues. It was actually, it was with, the agent was actually with one company, and then it was sold to another. Yeah. And so there's been a lot of jockeying back and forth. I talked to actually Jamshid Madahi about 2 weeks ago. He said they are going to start now with the second phase 3 study. And again, you know, Bill, this is going to take now, it's probably going to be a year and a half of recruitment and this and that. And then, of course, once they have their 2 pivotal phase 3 studies, then it's got to go to FDA. And so you're probably talking 2-3 years down the line still.
How was the first study?
Well, that's what I just showed you. In terms of the first study, sensitivity actually increased very nicely. It went up to 89% if you use 50% cut point for coronary artery disease. Now, interestingly, I also said specificity didn't really change, but sensitivity did, and that I think has to do mainly because this is the first study actually to compare a technetium agent to a PET agent. All the other studies have been meta-analyses in different populations. This is the first study in the same patients to receive both a PET agent and a SPECT agent. And in this study, I mean, there was a significant improvement in sensitivity. But again, I don't think that's necessarily because it's PET versus SPECT. I think it's more to do with the very high extraction fraction of flurpiridaz, which is linear basically to blood flow, which is going to improve the disparity between counts in normal regions versus abnormal. So you're able to detect a perfusion defect size. Okay? Again, I think it's kind of interesting that specificity didn't improve. I would have expected specificity to improve. But, you know, they were comparable. It was non-inferior, but it wasn't better necessarily. But sensitivity was clearly better. All right. Let's talk a little bit about, and I'm going to talk about a little bit more about this at another meeting coming up in May. But MIBG is a very interesting agent. As you know, it images denervated myocardium. Its uptake is dependent on active transport across the synaptic cleft. And you can see that in patients who have normal MIBG uptake, you can see homogeneous uptake in the myocardium. This is an abnormal patient where basically there's no uptake at all. And what we do in this study, in these studies, is we compare the mean counts in the myocardium as compared to the mediastinum, and we get a heart mediastinal ratio. Over 1.6 is considered normal, although there's a lot of there's a continuum which I'll show you. But obviously, the whole idea here is that normal myocardium will take up MIBG. So this is the normal noradrenaline reuptake system. As you can see, in heart failure, it's impaired. So just as with norepinephrine, MIBG cannot be taken up by nerve terminals in patients who have severe heart failure. Okay. And the other thing about it is not only is it not taken up, but what's taken up is not retained. It washes out at a very high rate. Okay? What's been shown, and this is the major publication in the literature, is the ADMIRE heart failure study. This was almost 1,000 patients with class 2 to 3 heart failure with low EFs. And you can see here that when you use a 1.6 heart mediastinal ratio, those with a less than 1.6 had a very high composite endpoint of death, heart rate progression, or cardiac death, as compared to those with a higher heart mediastinal ratio. This was also true in terms of heart failure progression, as well as arrhythmic death. And what's interesting here is that if you look at the patients who had cardiac arrhythmic death, either cardiac death or arrhythmic death, there were almost no events in people with a heart mediastinal ratio greater than 1.6. What's also interesting is that, we use other markers like BNP, et cetera, to identify who's at high risk and who's at low risk. And BNP in this study also, if you had a high BNP, you did worse than if you had a low BNP. If you had a low EF, you did worse than if you had a high EF. But look at the interaction between BNP and MIBG. So if you have a high BNP and you have a low heart mediastinal ratio, you do the absolute worst. But if you have a high BNP, even if you have a high BNP, if you have a high heart to mediastinal ratio, you do no worse than those who have a double negative, who have a low BNP and a high heart mediastinal ratio. So the imaging it drives tremendously in terms of how patients do. And this is also true with ejection fraction. If you have a low EF and a low heart mediastinal ratio, you do very badly. But you can still have a low EF. If you have a high heart mediastinal ratio, you do fairly well. In fact, not much different than someone who has a low EF and a low heart mediastinal ratio. So there are many different models that are used. The Seattle heart failure model is the most widely talked about. It includes a variety of different metrics, including ejection fraction and BNP, et cetera. And this is a study that actually looked at the value of MIBG. And what you'll notice is that if you look at the Seattle heart failure model alone and look at outcomes at 1 year, you can see that black curve. Look at what happens if you have a very low. Look at the red curve. This is with a heart mediastinal ratio as it's going down from high all the way up to low. Look at how mortality increases dramatically, okay? So what this shows us is that in any given patient who you clinically think might be at high risk, you can better refine their risk by using MIBG. Another example of the data, this is looking at reclassifying risk. So if you took all the people that were less than 10% mortality, you would find a small percentage of patients who are actually at higher risk based on MIBG. So not much benefit here, but look at the intermediate risk group, those with 10 to 20%. Okay, so in this particular model, half of them would still stay intermediate risk, but a 14% would go to high risk, and importantly, a third of them would go to low risk. Okay, and further risk stratification, even those with very high mortality risk, greater than 20% by the clinical model, still about a third of those patients would be reclassified into lower risk categories based on MIBG. So we think this is going to be an important addition. Not only that, there are some now data showing you might be able to identify patients at high risk for sudden death based on the heart mediastinal ratio and the amount of washout that's present. And in fact, if you look at these data, you can see when you look at patients with sudden cardiac death, they had a lower heart to mediastinal ratio than those without sudden cardiac death. Those with sudden cardiac death had greater washout than those without sudden cardiac death. And when you combine those two into an MIBG score, those with the higher scores did much worse in terms of having sudden cardiac death as compared to those without sudden cardiac death. And when you look at the actual sudden cardiac death and pump failure death, you can see that those with low MIBG scores actually did incredibly well. There were basically no sudden deaths over a follow-up period. So we think that this agent is going to be very important in terms of reclassifying risk. And in fact, there is a study going on right now. In fact, our heart failure group, we're ready to start enrolling patients in the ADMIRE-ICD trial, which is going to be now not only looking at diagnostics, but actually looking at how MIBG can guide therapeutics. So in this study, patients are actually going to be randomized either into a MIBG study where if the heart mediastinal ratio is greater than 1.6, they don't get an AICD, or less than 1.6, they do get an AICD, versus standard of care. And the idea here is to see if by using MIBG, you can identify who needs to have an AICD. Because right now, you know, everyone and their mother who has an EF less than 35 gets an AICD. And most of them don't fire, okay? So the idea is to try to selectively identify people who will actually benefit from an AICD. Because remember, putting in AICDs also has its complications, right? In terms of pocket infections, wound infections, etc. So this trial I think will be very important. Lastly, I just want to mention in terms of heart failure, there's also the issue of being able to look at sarcoidosis with PET imaging. This is something that is, in fact, in the most recent issue of JNC, there's been a whole other large study published looking at how you might not only be able to identify, but also monitor and track risk and benefit, a therapeutic benefit in patients who have sarcoid based on serial imaging. And we know there are different, and I think you've actually heard some of this before, in terms of being able to look at perfusion and FDG uptake and being able to clarify early and late stages of sarcoidosis. And there are very nice data showing that you can risk stratify based on perfusion and FDG uptake. And these are data from Ron Blankstein several years ago from their cohort series. Finally, there is also the ability to look at pyrophosphate imaging for cardiac amyloid. Who would have thought 30 years ago that we would be doing amyloid imaging with technetium pyrophosphate, which was really an agent that we use for myocardial infarction imaging, okay? But it turns out that, this particular agent is taken up in patients who have ATTR amyloid. And it's thought to be possibly due to the fact that there's a higher calcium load between those microfibrils of the altered protein strands. And so we can actually look at relative uptake in the heart versus the contralateral lung over those two areas of interest. And what's considered abnormal is a heart to contralateral lung ratio greater than 1.5 counts per pixel ratio. And believe it or not, that has 97% sensitivity and 100% specificity for identifying ATTR amyloid. As you know, AL amyloid is really a disease of the bone marrow. It's a disease of the plasma cells. It's something that requires chemotherapy. ATTR is different. It's senile amyloidosis, and it's thought to be actually a very strong contributor, potentially in many patients, of diastolic heart failure. In patients who have normal left ventricular ejection fractions who have diastolic heart failure, many of these patients may indeed have ATTR amyloid. And by being able to identify this also leads to the potential of developing therapeutic modalities to monitor the disease and also to potentially impact the course of the disease. So you can see in a normal patient up on top, there's no uptake basically in the myocardium, whereas in an abnormal patient, there's extreme uptake. And this is actually one of the patients we did in our laboratory showing very high uptake in the myocardium. So there are many things we're doing in nuclear cardiology today. It's kind of very broad in terms of its applications. We still do perfusion, but we're also doing a lot of other innovative things. And I think overall the future is bright for the field in terms of not only what we do from a SPECT point of view with different tracers, but also what we're doing at the PET level in terms of unique applications. Are there any questions or?
So the MIBG, is that abnormal regardless of the heart rate etiology?
Yes.
So it's not related?
No. So if someone has systolic heart failure, it's not diastolic heart failure, systolic heart failure. There are some studies actually in diastolic heart failure as well, but the bulk of the data are in patients who have low EFs, who have depressed left ventricular function. And again, the whole concept here is that if you have, either for one reason or another, you have low energy stores, you're not going to be able, that active transport mechanism isn't going to work. Hello? Let me call you back in 1 minute. I'm still in a lecture. Yeah. That energy transport system is not going to work, and you're going to get very low uptake of MIBG. Yeah. Well, if you have a low EF and you have a high heart to mediastinal ratio, what's been shown is your risk of cardiac death and sudden death is extremely low.
But at the cellular level, why would some patients would have a high value per percent?
Well, I mean, the uptake, that would indicate they have preserved ability, they still have active they're able to have active transport. So I guess what that would mean from a cellular level is that they're still having enough, they still have energy to have an active transport system, right? Irrespective of the ejection fraction. So at the cellular level, they're still working. As compared to someone who has extremely low, who has no uptake of MIBG, where basically the active transport system has collapsed.
What camera is Dr. Mahmarian used?
A plain old SPECT camera. Yeah. Now, some people have advocated using a general purpose collimator because remember that MIBG is a 159 kV radio tracer, so it's got higher energy. So you might want to use a medium energy collimator instead of a low energy collimator. Some of the concerns there is that you could get septal penetration. So what I mean by that is, you know, through the collimator, right? So if you have you get photons you don't really want getting through, okay? You can correct, Ernie Garcia has done several algorithms to try to correct for septal penetration using low resolution collimators, but most people use medium resolution collimators when using MIBG, iodine 123. And again, remember, this is a low dose of iodine. It's like 5 millicuries, and you know, the half-life of iodine is about 13 hours. So, all right, thank you.